Hi, myself Dr. Vijay Misra, Associate Professor, Edina Institute of Pharmaceutical Sciences, Sagar, MP. I am here with an interesting and learning episode of B.Pharma on the important unit of drug interactions, including introduction, definition and basis of drug interactions, mechanism of drug interactions, and factors contributing to the occurrence of drug interactions, which is one of the important units of section drug design of B.Pharma 8th semester. Let's start our episode by taking a look at what we are going to learn today. Module 1st, Introduction of drug interactions. Module 2nd, Definition and basis of drug interactions. Module 3rd, Mechanism of drug interactions. Module 4th, Factors contributing to the occurrence of drug interactions. Let's start our lecture with the general introduction of drug interactions. Module 1, Introduction of drug interactions. A drug interaction occurs when a patient response to a drug is modified by food, nutritional supplements, formulation excipients, environmental factors, other drugs, or disease. Interactions between drug-drug interactions may be beneficial or harmful. Harmful drug-drug interactions are important as they may cause 10 to 20% of the adverse drug reactions requiring hospitalization, and they can be avoided. The interaction is largely unpredictable because various factors like age, lifestyle, diet, and underlying disease of an individual can affect the likeliness that the drug will interact. Now, question arises, who is at the risk? Then answer is people who are taking multiple medications for extended periods of time. Second is patients with renal or hepatic impairments because their metabolism and excretion will be impaired. Module 2nd, Definition and basis of drug interactions. A drug interaction is an interaction between a drug and some other substance such as another drug or a certain type of food which prevent the drug from working correctly. In order to understand food, drug and drug nutrition interaction, it is important to understand how drugs work in the body. There are 4 stages of drug action for medicines administered orally. Stage 1, the drug dissolves into a usable form in the stomach. Stage 2nd, the drug is absorbed into blood and is transported to its site of action. Stage 3rd, the body responds to the drug and the drug performs its function. Stage 4, the drug is excreted from the body either by the kidney, liver, or both. An interaction can either increase or decrease the effectiveness and or the side effects of a drug, or it can create a new side effect not previously seen before. The consequences of drug interactions can be: first, reduce the desired effects of a drug; second, increase the adverse effects of a drug; third, result in unnecessary pain and suffering. However, on the other hand, drug interaction may increase the beneficial effects of a drug and can decrease the adverse effects of a drug. Dear students, now we move on the next module, that is module 3rd, Mechanism of drug interactions. The drug interactions may occur in the following conditions, like when there is an increase or decrease in the absorption of a drug into the body, distribution of the drug in the body, changes made to the drug through the metabolism of the body, and elimination of the drug from the body. Second, when two drugs that have either additive or cancelling effects on the body are taken at the same time. C, when one drug alters the concentration of a substance that normally occurs in the body, thus reducing or enhancing the desired effects of another drug. The overall drug-drug interactions may be classified in the following categories. First, behavioral drug-drug interactions. These interactions occur when one drug alters the patient's behavior to modify compliance with another drug. For example, a depressed patient taking an antidepressant may become more compliant with medication as symptoms improve. Second is pharmaceutic drug-drug interactions. These interactions occur when the formulation of one drug is altered by another before its administration. For example, precipitation of sodium thiopentone and becuronium within an intravenous giving set. Third one is pharmacokinetic interactions. Pharmacokinetics means what the body does to the drug. Pharmacokinetics is the quantitative study of drug movement in, through and out of the body. These interactions occur when one drug, the perpetrator, alters the concentration of another drug, the objective drug, with clinical consequences. The overall pharmacokinetic interactions are represented in figure. Figure shows different stages of pharmacokinetic drug interactions. Interactions during absorption. The rate and extent of drug absorption after oral administration may be grossly altered by other agent. Absorption of a drug is a function of the drug's ability to diffuse from the lumen of the gastrointestinal tract into the systemic circulation. Changes in intestinal pH may profoundly affect drug diffusion as well as dissolution of dosage form. For example, the absorption of ketoconazole is reduced by the co-administration of antacids or H2 blockers like ranitidine, famotidine that reduce the extent to which the ketoconazole tablet is dissolved. Formulation of insoluble complexes by the process known as chelation is another mechanism by which a drug interaction may lead to the reduced oral absorption. For example, fluoroquinolones, example ciprofloxacin, and divalent metal ions such as calcium and iron form an insoluble complex that results in reduced absorption of both the antibiotic and the metal. Interactions that decrease the rate of drug absorption may be of little importance, since the overall extent of absorption may remain unaltered. However, the drug interactions during absorption can be grouped as follows. A. Direct chemical interaction. Iron and tetracycline form complex. Antacids like aluminum or magnesium chelate with tetracycline, which decreases bioavailability of tetracycline. Cholestyramine interfere with absorption of digoxin, warfarin and thyroxine. B. Alteration of GIT motility. Purgatives decrease absorption of antidepressants and anticholinergic drugs like atropine, which decreases gastric emptying and delays absorption. Prokinetics, example metoclopramide, increases gastric emptying and absorption. C. Alterations in GIT flora. Broad spectrum antibiotics potentiate anticoagulants, decreases bacterial synthesis of vitamin K. D. Absorption from other sites. Local anesthetic like lidocaine and adrenaline delay the absorption and increases duration of action. Second category is interactions during distribution. Drugs may exist in plasma either reversibly bound to plasma proteins or in the free unbound state. The primary drug binding plasma proteins are albumin and alpha 1 acid glycoprotein. It is free drug that exerts the pharmacological effects. Drug may compete with each other for plasma protein binding sites, and when this occurs, one drug may display another that which previously bound to the protein. Displacement of a drug from its binding sites will therefore increase that agent's unbound concentrations, perhaps resulting in toxicity. Some drugs normally exist in a state of high protein binding, often exceeding 90%. Thus, even a small decrease in protein binding could significantly increase the free concentrations. Drugs which are normally highly protein bound and which might participate in binding interactions include anticonvulsants and warfarin. However, the drug interactions during distribution can be grouped as follows. A. Displacement from plasma protein binding sites. Sulfonamide with bilirubin causes kernicterus. B. Displacement from other tissue binding sites. When quinidine interacts with digoxin, then more digoxin is displaced from tissue binding sites, which results in toxicity. Third category is interactions during biotransformation or metabolism. The liver is the major site for drug metabolism. Other sites include the kidney and the lining of the gastrointestinal tract. The two main types of hepatic drug metabolism are phase 1 and phase 2 interactions. The two main types of hepatic drug metabolism are phase 1 and phase 2 reactions. Phase 1 oxidative reactions are the initial step in drug biotransformation and are mediated by the cytochrome P450, that is CYP system. This complex superfamily of enzymes has been subclassified into numerous enzymatic subfamilies. The most common CYP subfamilies include CYP1A2, CYP2C9, CYP2C19, CYP2D6, CYP2E1 and CYP3A4. These enzymes may be induced or inhibited by other agents, thereby leading to an increase or decrease in the metabolism of the primary drug. Phase 2 reactions occur following phase 1 reactions. In this process, drug metabolites are converted into more water-soluble compounds that can be more easily eliminated by the kidneys. A. Enzyme induction. It may result in increased CYP enzyme synthesis, faster drug metabolism, subtherapeutic drug concentrations and the risk for ineffective drug therapy. The rapidity of the enzyme induction is dependent upon the half-life of the inducing drug as well as the rate of synthesis of new enzymes. Examples of drugs that cause enzyme induction are the barbiturates, some anticonvulsants and rifampin. The interaction of rifampin with contraceptives cause failure of conception. The interaction of barbiturates with warfarin decreases the anticoagulant effect of warfarin. Cimetidine potentiate effect of warfarin and theophylline. B category is enzyme inhibition. It may result from non-competitive or competitive inhibition of CYP enzymes by a second drug, an effect that may occur rapidly. Examples: the hepatic enzyme inhibitors induce cimetidine, fluconazole and erythromycin. The result of non-competitive enzyme inhibition by addition of a second agent is slower metabolism of the faster drug, higher plasma drug concentrations and a risk for toxicity. In the case of competitive inhibition, the metabolism of both drugs can be reduced, resulting in higher than expected concentrations of each drug. A few drugs are metabolized by enzymes found in cells lining the gastrointestinal tract. One of these drugs is cyclosporine. Some foods and other preparations such as grape fruit juice contains certain substances that may inhibit these specific enzymes, resulting in elevated serum cyclosporin concentrations. Fourth, interactions during excretion. The majority of renally eliminated drugs are excreted via passive glomerular filtration. Some drugs are eliminated via active tubular secretion such as penicillins, cephalosporins, and most of the diuretics. The active secretion may be inhibited by secondary agents such as cimetidine, non-steroidal anti-inflammatory, that is NSAID agents, and probenecid, with resulting elevations in the serum drug concentrations and reducing urinary drug concentrations. Various drugs can interference with the active transport. Some drugs are excreted from the body unchanged in the active form, usually in the urine or by the biliary tract in the feces. Changes in renal drug clearance may occur due to effects on renal tubular function or urine pH. For example, probenecid reduces the renal clearance of anionic drugs such as methotrexate and penicillin. In some cases, the interaction is desirable, while others may lead to adverse therapeutic outcomes. Fourth category is pharmacodynamic interactions. Pharmacodynamic means what the drug does to the body. Pharmacodynamic drug-drug interactions occur when interacting drugs have either additive effects, in which case the overall effect is increased, or opposing effects, in which case the overall effect is decreased or even cancelled out. Pharmacodynamic interactions between drugs with additive effects may be intentional. For example, when combining antihypertensives, or unintentional, for example, serotonin syndrome caused by adding tramadol for a selective serotonin reuptake inhibitor, that is SSRI. On the other hand, combining drugs with opposing effects can result in the loss of drug effect. For example, reduced bronchodilation by a beta-2 agonist prescribed with a non-selective beta blocker. The brain is the organ most commonly compromised by pharmacodynamic interactions. These interactions can be categorized as follows. First one, drug synergism. In this, the therapeutic effect of one drug is enhanced by another drug. It involves addition. When the effect of two drugs having similar action are additives, the net effect of two drugs used together is equal to the sum of the individual drug effect, that is 1 plus 1 equals to 2. That is, thiazide diuretics with beta blocker have an additive antihypertensive action. Second, potentiation. When the net effect of two drugs used together is greater than the sum of the individual drug effects, that is 1 plus 1 is greater than 2 or 1 plus 0 is greater than 2, when one drug increases the action of other drug. Example, sulfamethoxazole plus trimethoprim will give cotrimoxazole, that is bactericidal. It involves 1 plus 1 is greater than 2, or when the drug has no effect as own but increases the effect of other drugs, that is 1 plus 0 is greater than 2. Example, L-Dopa and carbidopa. B category, drug antagonism. The effect of one drug is decreased or abolished by the administration of another one. This may be of three types, like physiological antagonism, chemical antagonism, pharmacological antagonism. Dear students, till now you have gained a complete idea about the general introduction of drug interactions, definition and basis of drug interactions, as well as mechanism of drug interactions. If you have missed any of the module or content, you may log on to our website, that is www.cec.nic.in, to download videos, FAQ, LOR and other contents so that you may remain updated with this chapter. Now, we move ahead to our next module, Module 4, Factors Contributing to the Occurrence of Drug Interactions. There are various factors which affect the drug interactions. These factors can be categorized as follows. First one is patient-related factors. Second is pharmaceutical factors. Now we discuss first one is patient-related factors. It involves membrane physiology. The membrane physiology further involves the membrane structure. Cell membrane, also called as plasma membrane, plasma lemma, is a phospholipid bilayer. The plasma membrane is a flexible yet sturdy barrier that surrounds and contains the cytoplasm of a cell. Second is transport process. There are different transport processes like passive diffusion, pore transport, facilitated diffusion, active transport and pinocytosis. Passive diffusion. It is a major process of absorption of more than 90% of the drugs. Diffusion follows Fick's law, that is, the drug molecules diffuse from a region of higher concentration to a region of lower concentration till the equilibrium is attained. Rate of diffusion is directly proportional to the concentration gradient across the membrane. Various factors affect the passive diffusion like diffusion coefficient of the drug. It is related to the lipid solubility and molecular weight. Second, thickness and surface area of the membrane. Third one is size of the molecule. Second transport system is pore transport. It involves the passage of ions through aqueous pores that have the pore size of 4 to 40 angstrom. Lower molecular weight molecules containing less than 100 Daltons molecular weight like urea, water, sugar are absorbed by this process. It is also important in renal excretion, removal of drug from cerebrospinal fluid, that is CSF, and entry of drugs into liver. Next is facilitated diffusion. It is also known as carrier mediated transport, downhill transport. It is faster than passive diffusion. No energy expenditure is involved in it and also not inhibited by metabolic poisons. It is important in transport of polar molecules and charged ions that dissolve in water, but they cannot diffuse freely across cell membranes due to the hydrophobic nature of the phospholipids. Example is entry of glucose into RBCs. Second is intestinal absorption of vitamin B1, B2. And third is transport of amino acids. Next system is active transport system. It is also known as carrier mediated transport, that is uphill transport. Energy is required in the work done by the carrier and it can be inhibited by the metabolic poisons. Endogenous substances that are transported actively include sodium, potassium, calcium, iron, glucose, amino acids and vitamins like niacin, pyridoxine. Drugs having structural similarity to such agents are absorbed actively like pyrimidine transport system, absorption of 5-fluorouracil, that is 5-FU. Second is L-amino acids transport system, absorption of methyl dopa and levodopa. Next mechanism is pinocytosis. It is also known as cell drinking and involved in uptake of fluid solutes. It is a form of endocytosis in which small particles are brought into the cell in the form of small vesicles, which subsequently fuse with the lysosomes to hydrolyze or to break down the particles. This process requires energy in the form of ATP, that is adenosine triphosphate. Example is polio vaccines, and large protein molecules are absorbed by pinocytosis. Next factor is gastrointestinal physiology. Different factors are involved in it, like characteristics of GI physiology. Second is GI motility and emptying. Third one is blood flow through GIT. Fourth one is influence of food. Fifth one is intestinal transit time. Sixth one is pre-systemic metabolism by various enzymes. The figure shows various factors which affect the gastric emptying. The type of meal, that is fatty food, it decreases gastric emptying. Carbohydrate decreases the gastric emptying. Second is drugs like anticholinergics, example atropine, narcotic, example morphine, alfentanil, analgesics like aspirin, they decreases the gastric emptying. Next is metoclopramide, domperidone, erythromycin, bethanocol, they increases the gastric emptying. GI motility tends to move the drug through the alimentary canal so that the drug may not stay at the absorption site. Example, cathartic drug increases gastric motility and decrease drug absorption of another drug. Since intestine is the major site of absorption of most of the drugs, long intestinal transit time is desirable for the complete absorption of the drugs, which delayed intestinal transit is desirable for drugs that dissolve only in intestine, that is enteric coated drugs, and drugs absorbed from a specific site in the intestine. Interaction of drugs with gastrointestinal content like mucin, enzyme and bile salts influence drug absorption. Example, bile salts increases absorption of vitamins like solution and decrease absorption of neomycin and kanamycin that form the insoluble complex. There are various pharmaceutical factors which mainly involves the physicochemical factors. It includes the pH of the system, drug solubility and dissolution rate, particle size and effective surface area, polymorphism and amorphism, pseudopolymorphism and salt form of the drug. Unionized drug shows higher absorption while ionized drug shows lower absorption. As given in the figure that weak acids like pentobarbital and aspirin and weak base like theophylline, caffeine, codeine shows high absorption, while strong acid like disodium chromogylate and strong bases like guanethidine shows low absorption. When substance exists in different crystalline forms, it is polymorphism. However, amorphism drugs can exist with no internal crystal structure. Such drugs represents the highest energy state and can be considered as supercooled liquids and thus have greater solubility like novobiocin. Thus, the order of dissolution and absorption for different solid dosage form is amorphous is greater than metastable, which is greater than stable. The salt of weak acid and weak bases have much higher aqueous solubility than the free acid or base. Therefore, if the drug can be given as a salt, the solubility can be increased or the dissolution thus can be improved. The formulation factors are disintegration time, manufacturing variables, pharmaceutical ingredient which involves excipients and adjuvants. Next is nature and type of dosage form and product age and storage conditions. Rapid disintegration is important to have a rapid absorption. So, lower disintegration time is required. In vivo disintegration keeps no means of guarantee of drug bioavailability, because if the disintegrated drug particles do not dissolve, then the dissolution is not possible. Then dear students, in conclusion, we can say there are various ways to find more information regarding the drug interactions, like first one is talk to a healthcare provider, ask the doctor about the prescribed medications. Second is talk to a pharmacist. Third one is read the information that accompanies the medication. Fourth one is search about the prescribed drugs at a local library or on the internet with the reliable and valid sources like www.drugs.com. However, some area of concern involving the ways of preventing drug interactions are as follows. First one is prepare a list of all medications that they are currently taken or have used in the last 3 to 4 weeks to the healthcare providers. This list should include over-the-counter medications, vitamins, food supplements and herbal remedies. Second one is keep the list of medications current and inform healthcare provider when any drug is added or discontinued. Third one is report any changes in lifestyle like diet, exercise to healthcare provider. Fourth one is ask healthcare providers about any possible drug interaction that may occur with a medication. Fifth one is work with healthcare personnel to eliminate any unnecessary medications since the chance of experiencing an interaction increase with the number of drugs being taken. Sixth one is pay attention and record time of day when medications are taken. Dear students, with all these information, there we come to the end of the today's lecture. Do keep in mind what we have discussed today. This is time for your self-study. If you want to learn more for enhancing your knowledge, you may log on to our website, that is www.cec.nic.in for MCQ, quiz and LORs. Dear students, in the end, I want to say that be aware, be comfortable and be actively involved in the treatment or drug therapy process to avoid any unwanted drug interactions. Till then, keep studying. Goodbye.